So we do have quorum, so that's great. As it is 7:15, so we'll start the meeting. So I'll just quickly go over the bullet points regarding the meeting. Um, you are going to be recorded, so you'll see on the top left that the presentation is being recorded. And then if you are on the phone, just note that you are also being recorded regarding the voice. So once again, good morning, everyone. Thank you for joining October's DUR. And so if you are dialing in via telephone, Google Hangouts has muted you. So if you do need to speak to the group, just press *6 on your phone to unmute and mute yourself. If you are using your laptop for audio and visual during the meeting, you could control the mute function, which is located at the bottom of the screen. We just ask that only those who are speaking to the group unmute their devices to prevent any background noise. So remember, DUR board members reserve questions till the end of the presentations, or you may ask in the Google Hangout chat, and that's the chat function on the right side. And then public comment, if you would like to provide public comment, a conflict of interest form must be on file. And so you could send that to medicaidpharmacy@utah.gov. And attendees that are not members of the DUR board, please enter your contact information via Google Meet chat if you are joining us via video. If you are on the phone, just email us that you have attended so we could document that on our notes at medicaidpharmacy@utah.gov. So with that said, at the end of the meeting, we're always looking forward to anyone who wants to provide normative feedback. We want to improve. So if you guys want to stay towards the end and give us feedback, I really appreciate that. But with that said, we'll take it away.
All right. So since we have a quorum, it seems the next thing is the housekeeping items. Is that correct?
Mm-hmm. So actually, the biggest housekeeping item is that today will be my last day with Utah State Medicaid, but your new DUR manager is going to be Noon. So Noon, if you want to just give if you'd like to take the floor for a few minutes and just introduce yourself to make sure everyone is aware, that would be awesome.
All right, thanks, Mo. Yeah, my name is Noon. We're very sad to see that Mo's leaving us today, and today his last day. I will be taking over the DUR starting for the month of November and go on. It's my pleasure to be working with the board. Thanks,
Thank
Mo.
you, Noon. So that is, I think that's the biggest housekeeping that we had. But yeah.
I do have one other item, if I could, please.
Yes.
Yeah, thanks. So I did want to update the board that, and Eric was on this meeting as well, but we did meet with the ACOs this week to begin discussions around a study for a unified PDL. And so I think I touched on this last time, that there had been a legislative audit conducted last year and into the spring, and the findings of that audit were to conduct a unified PDL analysis to look at the financial impact. We're also evaluating other impacts, such as just delivery of pharmacy services, impact on providers, impact on patients, impact on the ACOs if this were to be implemented. And this is very timely with what's happening across the country, where almost 20 states have adopted a unified PDL and have also carved back pharmacy services. So Utah is evaluating that option, and that study will be initiated this month.
Great, thank you. Okay, next item is review and approval of minutes. Any changes? Go ahead, Kumar. You're gonna unmute yourself.
If you put the mouse down at the bottom of the screen, it'll bring up a couple of controls. The one on the left side, the microphone, is the one that you'll click on. Sorry, Kumar, we're still having trouble hearing you.
Fortunately, I can't unmute.
Do you want to try typing your question in?
Kumar moves that we accept the minutes, and I would second that.
All right, perfect. Okay, all those in favor of approving the minutes signify by saying aye.
Aye.
Or raising your hand. Aye. Any opposed?
Aye.
Aye.
All right, looks like we have approved minutes. Thank you very much for that. And next we have the P&T committee update.
Yes, we met last month in the P&T committee, and we discussed biologic treatments for asthma. And so we hope to get those added to the preferred drug list early next year. And next month, we'll be discussing immune globulins.
Sounds good. Perfect. All right. The next item then is the DUR annual report from the University of Utah, DDRC.
Hello, this is Joanne. Can you all hear me?
Yes, we can.
Yes.
And should I share my screen?
Yes.
I can share my slides with you all. All right, can you all see the slide?
Yeah.
Yes.
Terrific, thank you. So this is our presentation of the annual report. This is the second year that we're doing this presentation. So we're just presenting kind of some details about what we're doing and some of the results that we're finding. Time permitting, this is what I'm hoping to go through today. I'm going to just kind of introduce you kind of to the background and the rationale. We're going to talk about patient reviews, one of our largest mission of the work that we've been doing for the Utah Medicaid drug program. We'll also talk, time permitting, a little bit about the reviews that we do for the DUR board, which many of you are familiar with, obviously, and P&T committee reviews. So this is just the statement about the three missions that I told you about. Throughout this year, or this past year, the period covered by this report, which goes through September of 2019, from October 2018 through September 2019, we've been conducting retrospective patient-level drug utilization reviews of the drug therapy of Utah Medicaid patients who meet various criteria for high risk for utilization. And then we've been supporting the Utah Medicaid Drug Utilization Review Board's requirement to conduct retrospective and prospective DUR by providing reports of utilization and evidence-based recommendations for minimizing risks of future drug therapy problems. And then we've been also supporting the P&T committee by providing evidence about comparative safety and efficacy for medications under consideration for Utah Medicaid's PDL. So those are the types of work that we've been doing, and this is a list of the staff who have contributed to the work in this annual report. And this slide actually comes from the Commonwealth Fund. This table does. It just shows the historic increase in expenditures for prescription drugs by countries. And the United States has long been an outlier, since the 1990s, has been an outlier in terms of the amount of money that we spend compared to other countries on prescription drugs. In the late 1990s and the early 2000s, it was kind of reaching a point of where it was beginning to feel critical, and states all over the country were beginning to implement controls to try to reduce the increase in prescription drug expenditures. We began working with the Utah Medicaid program in about 2001 and doing patient level drug reviews in 2002. And this slide shows just kind of the historical trend in the numbers of patients who have been utilizing prescription drug benefits over that time. So you can see that prescription drug numbers of patients utilizing drugs continued to increase. There was, this sort of pattern of increasing and decreasing in each quarter, which I think is driven a lot by the numbers of high volume days, pharmacy days in each quarter, which tends to be typically Mondays or Fridays are high volume days for pharmacies. But as you can see, when Part D was implemented, there was a downward trend in the numbers that then began to increase again. And it has been, despite, the ACA provisions going into effect, it's been relatively consistent in terms of the total numbers of patients who are utilizing prescription drug benefits. The blue line is all Medicaid programs, and the red lines are the fee-for-service subset once the ACOs were implemented. So this is a subset of all Medicaid recipients. This slide shows the similar historical pattern, but looking at numbers of prescriptions. And so you can see there's a dramatic decrease when Part D was implemented as some of the highest volume patients moved into the Medicare program. And in terms of numbers of prescriptions and even numbers of patients, we've never quite gotten back to pre-Part D levels. But when we look at expenditures, we've got unadjusted at the top, so these are just raw dollar amounts, and adjusted for inflation at the bottom, so that these are reported in 2019 dollars. And you can see that just this year, for the first time, prescription drug expenditures have reached kind of the peak where they were at the highest point before Part D implementation. And that's despite serving a smaller number of patients and paying for a smaller number of prescriptions. And it's because prescription drug prices have continued to increase dramatically over that period. So let's talk for a minute about the patient reviews that we do. So this is just kind of our rationale for how we got started. In 2002, the Utah legislature passed a law that limited Medicaid recipients to only 7 prescriptions per month. And that was following that period of rapid growth that we talked about previously. But rather than implementing the 7 prescription limit immediately, the Department of Health, the Utah Medicaid program contracted with us to conduct patient reviews with the goal of helping to implement the limit. So initially, we focused on the highest utilizing patients, and the goal was to see if it was possible to get patients under 7 prescriptions per month. However, a lot of the patients had a high level of comorbidity and disease acuity, and there were a lot of patients who really did need 7 or more prescriptions a month. And this is common. You can imagine a patient with, a mental health disorder and perhaps type 2 diabetes, and they've got prescriptions for mental health drugs, for anti-diabetic agents, for anti-diabetic test supplies. And then, patients with type 2 diabetes are at a higher risk also often for acute infections. And so there were often acute, antibiotic prescriptions and things like that. And so we never really got to the point where the state of Utah, the Medicaid program, decided to implement the limit officially, but we continued to serve the population by providing feedback to clinicians about ways that they could optimize patient care. And it wasn't always a focus on getting costs down, because as you know, it's also about making sure that patients are being treated appropriately. because inappropriate drug therapy ends up costing more on the medical side. And so that's been our focus ever since. We have changed our methods for selecting patients for review in each month. Initially, we reviewed 300 patients a month, and most of those were selected just on the basis of high utilization. But starting in 2008, we decreased to 150 patients a month, and we had 3 different selection methods, including high utilization, high comorbidity using a comorbidity index called the RX risk, and then looking for patients with a high number of chronic diseases using the chronic disease identification metrics based on the RX risk tool. And then in 2011, we changed again so that the third criterion, rather than being the count of chronic diseases, was a variable rule that we would choose based on patterns that we were seeing. And then starting in 2013, we began working only to sample patients from the fee-for-service subset of Medicaid recipients because the accountable care organizations were doing this kind of work for their own patients that they were serving. So our present patient review methods are that, or at least through this reporting period, we've been selecting patients using those 3 methods of the variable rules, the high comorbidity risk, and the highest number of prescription fills per month. In terms of the total numbers of reviews that we've done since, sorry, this says September 2019, but it's actually not, I mean, this goes all the way back to 2002. Using all of the methods, the patient selection, the DRRC has reviewed the drug regimens of 30,000 patients, or 30,000 separate patients. 17,000 of them were unique patients. So as you can imagine, patients came up for re-review periodically over the years. We typically excluded patients who had been reviewed in the prior 6 months. And then if they came up for re-review, we would consider reviewing them again. We've sent out more than 67,000 reports. Initially, it was by mail, and then we switched to fax, phone, mail, or email, most frequently fax. Most Medicaid recipients have received multiple reports, or sorry, most Medicaid prescribers have received multiple reports on behalf of multiple patients, and more than half of patients have had reports sent to multiple prescribers. And then feedback to and from prescribers is communicated primarily by phone or fax. This slide just gives a little bit of information about that comorbidity score tool that we use to identify patients who are at high risk. So comorbidity scores, there are several different indices that are highlighted here in blue. These are used for case mix adjustment when we're comparing 2 or more groups of patients. That's probably the most common way of using these tools. The Charlson Comorbidity Index and the Elix-Hauser are based on diagnosis, while the Chronic Disease Score, or RX risk, and the Medication-Based Disease Burden Index, these are based on prescriptions. An advantage of the prescription drug-based indices is that patients fill prescriptions every month, and so you often have more data points to try to determine which diseases patients have, whereas diagnosis codes are only submitted when there's a clinical encounter, and even then, it may only be a subset of the codes that get submitted. So using the prescription drug-based tools, we think is more accurate. This tool is validated to identify patients who are at both a high risk of having hospitalizations, a high risk of having high costs in the next year, and a high risk of death in the subsequent year. The RX risk V was an update of the original tool because it's had to be updated over the years as new drugs come to market. So basically, each drug that a patient receives is assigned a coefficient from the predictive model, and the coefficient for each disease state corresponds to the predicted cost associated with the disease in the subsequent year, and then the sum of the coefficients corresponds to, like I said, a higher risk of death and a higher risk of hospitalization. The coefficients are scored to get a total RX risk score for that patient. The RX risk sum, that's the count of disease states. And the patients with the highest score or the largest sum have been selected for review over the years. The variable rules have varied over the years. This year was the first year that we began to use to adapt validated, standardized tools created or measures created by the Pharmacy Quality Alliance. Prior to February of this year, we were defining our own rules on the basis of the patterns that we saw. And this year we began to use these PQA metrics. And our first ones that we implemented had to do with adherence. And we looked at oral antidiabetics, statins, renin-angiotensin receptor blockers, beta blockers, calcium channel blockers, and novel oral anticoagulants. In terms of the review process, we have to wait until the month closes, and so before the data are ready for us to be able to start to process it. So typically 1 to 2 weeks after the end of the prior month, our analyst goes in and downloads the data to the secure university servers that are behind the firewall, and they process that information to identify patients who meet the criteria. And then the patients who meet the criteria in each month are populated into an Access database that we developed for the purpose of conducting the reviews. And the pharmacists review the patient's utilization history. The focus is on the medications in the month of review. But we also have information about prescription drug fills for the prior year, things like procedure codes and diagnosis codes that have been submitted over the prior several years, up to three to 5 years, and then just kind of reviews all that information and tries to identify and document any potential drug therapy problems. Recommendations are sent by fax or phone or email or mail to one of the patient's prescribers. We tend to send most of them by fax, but we call if we see a serious problem. So situations where we've called have been things like when we see warfarin doses that strike us as being completely out of range, or patients are on multiple drugs from the same classes and have been, and at dosages that concern us in terms of safety. We identify drug therapy problems. We have some predefined drug therapy problems that we look for, but we also kind of look for additional things. This is just a list of some of the drug therapy problems that we've used, or categories that we've defined and that we will identify for providers. And then we will identify the providers, or the drug therapy problem for the provider, tell them kind of the best practice, citing guidelines and evidence, and make our recommendation on that basis. Just in the way of a few cases that we just wanted to share, every year we kind of look through and look for some what we call the gold star cases. These are cases where we've done an intervention and we're following the patient to see what happens. So patient number 1 was a 61-year-old female that regularly filled prescriptions for several medications, including olanzapine, but she also had diagnosis codes that included bipolar disorder and abnormal weight gain. We advised the prescriber that olanzapine is among the second-generation antipsychotics with the highest risk for weight gain, diabetes, and increased lipid levels, and suggested an alternative agent with a lower metabolic risk. We recommended aripiprazole, and upon subsequent review, the patient had been switched to aripiprazole. Another patient was a 51-year-old female who regularly filled prescriptions for estradiol and medroxyprogesterone acetate injection without any supportive diagnoses for at least 2 years. We advised the prescriber that if the woman was pre or perimenopausal with an intact uterus, oral estrogen with oral micronized progesterone might be a better choice due to its lower excess risk of cardiovascular heart disease and breast cancer. And our recommendation was accepted upon subsequent review. A 42-year-old male patient with a heart failure diagnosis that hadn't been defined as reduced or preserved ejection fraction filled prescriptions for hydrochlorothiazide and nebivolol. And we advised the prescriber that if the patient had reduced ejection fraction, to consider the use of a beta blocker that's proven to reduce mortality in clinical trials, such as bisoprolol, carvedilol, or metoprolol sustained release. and that the FDA had rejected nebivolol approval for heart failure in 2010. And additionally, we recommended the addition of an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker and an aldosterone antagonist if the patient had even mild symptoms such as fatigue or shortness of breath with usual activities. A review of the patient profile 6 months later found that the therapy had been changed to lisinopril, bisoprolol, and aldosterone. A 41-year-old female had a diagnosis code for type 2 diabetes that had been untreated pharmacologically for at least 2 years. There was also a lack of procedure codes for a laboratory assessment during that time, and so we advised the prescriber to check the patient's hemoglobin A1C, urine microalbumin, and lipids if it has not been done in the last 5 years. We also provided a summary of the American Diabetes Association standards for medical care in diabetes, and over the following months, the recommended laboratory tests appeared to have been ordered according to the procedure codes, and the patient had begun to receive Janumet, insulin, Detamir, and atorvastatin. Patient 5 was a 29-year-old female with diagnosis codes for ADHD, and she had received prescriptions for a benzodiazepine and a stimulant. The indication for the use of benzodiazepine was unclear from a review of submitted diagnosis codes. Information was sent to the prescriber stating that concurrent stimulant and benzodiazepine use is typically not supported by guidelines or currently available evidence. And in addition, current guidelines don't recommend benzodiazepines as first-line treatment for anxiety or insomnia or for the treatment of stimulant adverse events. So upon a review of the medication fill profile later, we observed that the alprazolam therapy had been discontinued and not restarted at 9 months. And then patient 6 was a 62-year-old female who'd been filling prescriptions for oxycodone and acetaminophen, morphine, and amiodarone. Diagnosis codes were for chronic pain syndrome, end-stage renal disease, and hemodialysis dependence. We advised the prescriber that amiodarone increases morphine and oxycodone exposure, that a long-acting opioid may reduce breakthrough pain, constant pain awareness, and provide a better quality of life, and that oxycodone and morphine both have active metabolites that may accumulate in the setting of renal dysfunction, leading to severe and prolonged respiratory depression. We recommended conversion to a long-acting opioid product such as a fentanyl patch, assessment of pain control, and a dosage reduction to the total daily opioid dose limit recommended by the CDC, and prescribing only a single short-acting opioid for breakthrough pain. And upon subsequent review, the prescriber had discontinued morphine therapy but had not implemented other suggestions. So those are just some examples of the kind of impact that we have on patient care. We also solicit feedback with each recommendation. So this is an example of a drug therapy problem that we identified. We give an assessment of what are the patterns that we're observing and then provide a recommendation. And then we ask the prescriber how useful was the information and how likely are you to implement the recommendation. And they can submit a comment if they would like. And they can fax this back to us. And I have a slide later that shows kind of some of the feedback that we get. This slide summarizes the numbers of patients who were reviewed in the current reporting period. Earlier in the reporting period, we weren't flagging as many patients on the variable rule, and so we had to catch up toward the end of the year because we do 1/3 of each. And this slide summarizes the numbers of patients who were reviewed in each month. And as you can see, this was toward the end of the month of the year when we were realizing that we hadn't flagged enough of the variable rule patients. This slide summarizes the drug therapy problems that we identify. The largest and most common drug therapy problem that we identify, it tends to be adherence, and this has been for the last many years. We looked at the disease categories of the drugs where adherence was a consideration, and these are things like antidepressants, antidiabetics, and anticonvulsant drugs. Oh, and cardiovascular drugs are the largest number. We also have a lot of patients where we identify untreated indications. Patients seem to need treatments like the patient with type 2 diabetes, where we saw that she hadn't been assessed for a while and wasn't being treated. We often will recommend alternative treatments, usually for clinical reasons, as in the patient who had renal dysfunction with the high doses of opioids. And then additive toxicity, where two drugs are working together and to increase potential toxicities such as respiratory depression and so on. So you can see that we have kind of the most frequent ones there are at the top. And then these are the identified drug therapy problems by selection method. So not surprisingly, because we were implementing PQA adherence rules in this year, adherence was most frequently identified as a problem in patients who were identified using the variable rule, but we also had patients who were identified with all of the other metrics where adherence was pretty frequent. So that tended to be independent of selection method, as well as subtherapeutic dose was also appeared to be independent of selection method. Additive toxicity, therapeutic duplication, and drug-drug interaction and excessive dosing were predominantly made among patients who were selected by pill count, which makes sense because those are the kinds of problems that would be associated with a higher number of prescriptions that you're taking in each month. In terms of the historical pattern of drug therapy recommendations in each year, so this shows the numbers of the historical trends in the different problems that we've identified. So early on, I think we were reviewing 300 patients a month, which accounts for the higher volume. And that accounts for, having many more recommendations per year. But in addition, things like consider alternative was the most frequent one, but that's when Medicaid was initially prohibited from having a preferred drug list. And the preferred drug list became effective in May of 2009, which is where we began to see that. And then in addition, we also reduced the number of patients that we were reviewing to 150 a month in October of 2008, which is why we saw the volume going down. And over the last years, adherence, as you can see, a problem that we've identified. In terms of quality feedback, we often find that with our patient drug reviews that we don't get feedback, and we'll go in and we have some patients, like I said, the gold star patients, where we follow them over time, and we don't always hear from those providers. But when we do hear back, we had an average general usefulness score of 4 on a scale of 1 to 5, and a likelihood of implementing of just under 3 on the same scale, where 5 is would be useful and or a high likelihood of implementing. And then these are just some of the comments that we have received back. And this shows just the change in fill count overall. So this is for all patients in the review month, the average number of fills, those selected for fill count, those selected for risk score, those selected using targeted intervention method. And so as you can see, that the A is number of prescriptions then the blue is the number of prescriptions in September of 2019, and then, black is in September of 2019. So this is comparing everyone that was reviewed. The blue is just looking at everybody eligible in September 2019. Because these numbers, the black bar includes patients who were not, only includes patients who were still eligible. So we wanted to be able to also have a comparison of the same patients if we could, whereas the gray bars include everybody that was selected at ACE. Changes in drug therapy problems. So patients who are selected on the basis of the variable rule, we had initiated a process of evaluating them after 6 months to determine if they would still meet the requirement for the selection rule as a measure of the effectiveness of our intervention. And so these are the numbers with drug therapy problems in each month. And then in the follow-up month, which was 6 months later, the number that are still eligible. And so a portion of the reduction in patients who would still meet the criterion is a function of some patients not being eligible. But this is the percentage reduction of people who would be still eligible for being classified as having that drug therapy problem 6 months later. out of only the eligible subsets. You can see that we have a high level of effectiveness in terms of the percentage reduction. And then this shows the percentage reduction overall when you take into consideration both effects. So some people were not still being followed up, and that most of the patients no longer had that drug therapy problem. We also look at costs, even though costs are not, prescription drug costs are not the specific focus of our program. We do look at costs in the month of review and then in the subsequent month. And our methods are, we look at, cost in the month of review and then in each subsequent month. And we assume, that the month of the review is the baseline, and that if they were continuing to fill, that on average, the same prescriptions at the same cost level, on average, it would be the same in each month, even though some months might be a little higher and some months might be a little bit lower. And so any difference from that baseline month is, we estimate that to either be an increase or a decrease, depending on that change. And I've got the changes, the cost change from baseline is summarized here by review month. And so we have, so because we only follow until the end of the year, so for some patients, we are following over 1 month. And so patients in these last months, so the savings aren't as high in terms of the reduction in prescription drug costs. But we presume that at the end of the year, 1 year period, that some of those cost savings do continue. In the reporting period, we estimate that the difference costs in the selection month and what they would have been if that trend had continued was a savings of about $3.7 million.
Excuse me 1 second. Just a reminder that if you could please mute your microphones. We do have some background noise in the back. Just a heads up there. Thank you.
So of course, there are some limitations inherent in the review process. We're only looking at historical information. We're limited to claims information only. For evaluation of changes in drug therapy problems, we're limited to only evaluating the changes for the variable rule problems. Assessment can be automated for those. Changes from baseline are estimated only in the subset of patients who remain eligible during the follow-up period, but we can't predict what outcomes would have been for patients who are no longer Medicaid eligible in the follow-up period. And cost estimates are based on reimbursed amounts, which don't factor either the federal contribution or the rebate amount. So in terms of the real cost to the Medicaid program. So to summarize, patients selected for review are served by the DRC in material ways. Drug regimen adjustments are targeted to improve care, but they can also lower expenditures. Physicians receiving recommendations of the DRC are also served. They receive a comprehensive portrait of patients' drug therapy, including the drugs prescribed by other providers, which they may not otherwise know about in a fee-for-service environment, and information about patients' adherence. And they also receive educational interventions for improved patient care, as some of those gold star cases illustrated. It's 7:53. Jennifer, do you want me to continue on? The last few slides are really just about the DUR board work we do, for those just summarizing the numbers and topics, which I think everybody on the board is aware of. And then the P&T similarly is just kind of, we're going to talk about our process and our timeline and things like that. But do you have, I know there are other topics to address today. Would you like me to continue or?
Yes, I think for the sake of time, we should probably, if you can kind of summarize and the bulk of, I think what the board may be less familiar with is the work you covered, is your patient reviews. So I think it'd be great to have discussion around that if there are any questions or thoughts. And Dr. Weinstein's asking to share the slides, so that would be great once we get that.
Absolutely. Yeah, I sent the slides yesterday, but I'll resend them today to you, Jennifer, and Mohit and Noon, and you guys can hopefully send it out to everybody. So I can stop presenting, and are there any questions that I can answer? Well, thank you so much, everybody, for giving me this opportunity to present. I always enjoy talking about our work. So thank you very much.
Thank you.
Welcome.
All right, that leads us to HIV PrEP and PEP from the pharmacy team.
Hello. Please let me know if you see my screen.
Yes, we can see your screen and we can hear you now too.
Oh, thank you. So I'm going to present the Truvada and Descovy for re-exposure prophylaxis, PrEP, and post-exposure prophylaxis. We are presenting this for your information and no motion is required from the board. I'm going to talk about the Revalent, the pre-exposure prophylaxis, post-exposure prophylaxis PEP, including the non-occupational post-exposure, occupational post-exposure, comparison between Truvada and Descovy, looking at some Utah Medicaid claim statistic, and other state refer drug list, the SSDC state, and I make a proposal for referring drug list. Looking at the Revalent, for the world, in 2019, there were 38 million people across the globe with HIV and AIDS. Within that, 36.2 million were adult, 1.8 million were children under 15 years old, 1.7 million acquired HIV in 2019. That was a 23% decline in 2010. 81% aware of their infections, 19% still need access to HIV testing service. 25.4 million people with HIV were accessing antiretroviral therapy in 2019. 690,000 people would die from AIDS-related illness in 2019 versus 1.1 million in 2010. For the United States, 1.2 million people in the US are living with HIV in 2018. 36,400 people new HIV cases in the US in 2018. 1 in 7 is about 14% was unaware of their infections and need testing. Annual infection in the US have been reduced by more than 2/3 since the height of the epidemic in the mid-1980s. 15,000 be dead among people with diagnosed HIV in 2018. Looking at the chart, this is the new diagnosis of HIV in 2014 to 2018 in the US. Among the 30,968 new HIV diagnosed in the US in 2018, 69% was among gay, bisexual, and other men who have sex with men. 24% was among heterosexual. 7% was among people who inject drugs. The graph column demonstrates a further breakdown in category of race and sexual orientation among groups that were diagnosed with HIV in 2014 and in 2018. So among those, African American gay and bisexual men, white gay and bisexual men, African heterosexual women, and African American heterosexual men are the group that have an increase in new HIV diagnosed in 2018 compared to 2014. However, the Latino gays and bisexual men, Latino heterosexual women, white heterosexual women, and people who inject drugs are groups that have the reduction in new HIV diagnosed in 2018 compared to 2014. The map shows the rate of new HIV diagnosed for adult and adolescents in the US and dependent area in 2018. Per CDC, the highest rate of new HIV diagnosed were mainly in the South. When we're looking at the map, the lightest blue indicates states that have rate less than 10 new diagnosed per 100,000 people. Utah is one of those states that have the rate of 2.8. And the darker blue indicate a state that have the rate more than 20 to 29.9 new diagnosed per 100,000 people, such as Louisiana, Florida, and Georgia. There isn't any state that have the rate higher than 30 new diagnosed per 100,000 people. Pre-exposure prophylaxis and PrEP is the use of antiviral medication to prevent the acquisition of the HIV infections, to reduce the morbidity, mortality, and cost to individual and society. PrEP is used by the people without HIV who are at risk of being exposed to HIV through sexual contact or injection drug use. This is from the CDC guideline. For the summary of guidance for PrEP use, it's split into men who have sex with men, heterosexual women and men, and persons who inject drugs. For detecting substantial risk of acquiring HIV infections, men who have sex with men have these risks, that is, who has HIV positive sexual partner, recent bacterial STI, high number of sex partner, history of inconsistent or no condom use, or commercial sex work. For heterosexual women and men who has higher risk for HIV when they have HIV positive sexual partner, recent bacterial STI, high number of sex partner, history of inconsistent or no condom use, commercial sex work, or in high HIV prevalent area of network. For persons who inject drugs, at higher risk for HIV when have HIV positive injecting partner or sharing injection equipment. They are clinical eligible for PrEP when they have documented negative HIV test result before prescribing PrEP, have no sign or symptom of acute HIV infections, have normal renal function, no contraindicated medication to PrEP, have documented hepatitis B virus infection and vaccination status. People who use PrEP is recommended to taking daily continuing oral dose of emtricitabine and tenofovir disoprosyl fumarate, or a brand name is Truvada, daily. There are other services in combination with Truvada to providing PrEP is following visit at least every 3 months to provide HIV tests, medication adherence counseling, behavioral risk reduction support, side effect assessment, STI symptom assessment. At 3 months and every 6 months, thereafter assess renal function. Every 3 to 6 months recommended to test for bacterial STI. They are also recommend to do oral rectal STI testing, providing pregnancy tests every 3 months, or having access to clean needles, syringes, and drug treatment services. It's worth knowing that this guideline was published in 2017, and Descovy was approved for PrEP in 2019, and therefore not included in this guideline. Descovy, or generic is emtricitabine and tenofovir alafenamide, was approved by FDA in October of 2019 for at-risk adult and adolescents as a second drug to reduce the risk of HIV-1 from sex as part of ongoing efforts to end the HIV epidemic. Descovy excluding those who have receptive vaginal sex because the effectiveness in this population has not been evaluated. We're going to talk about PEP, and this is for non-occupational post-exposure prophylaxis. It's recommended at a 4-week or 28-day course. Recommended for HIV uninfected person in less than or equal 72 hours after a non-occupational exposure to blood, genital secretion, or other potentially infected body's fluid of the person known to be HIV infected or unknown HIV status when that exposure represents a substantial risk for HIV acquisition. The referred and alternative antiretroviral medication for 28-day regimen for NPEP for adult and adolescents older or equal to 13 years, including pregnant women with normal renal function. The refer is Truvada with protecravir, or a brand name is Icentris, or daclutavir, brand name is Tivicase. 1 daily of Truvada
and Isentress twice daily, or TVK once daily. For occupational PEP, a 4 weeks or 28-day course of PEP regimens is recommended for healthcare personnel as soon as possible after an occupational exposure to HIV occur. Ideally, is within 72 hours. Recommended is Pralteravir 400 mg twice daily, plus Truvada 1 by mouth daily. The comparison between Truvada and Descovy. Descovy is approved for treatment of HIV-1 infections. A second indication is for PrEP in at-risk adult and adolescents weighing at least 35 kilograms, excluding individual at risk from receptive vaginal sex. Descovy is a combination between amtrocitabine and tenofovir alafenamide at the dose of 200 mg, 25 mg, recommend to use once daily for both of the indication. Truvada is indicated for the treatment of HIV-1 infections and also indicated for PrEP at the risk adult and adolescents weighing at least 35 kilograms. Truvada is recommend once daily for the treatment of HIV and also weight-based if the patient is weighing between 17 kilograms and more, or even less than 22 kilograms. For PrEP, it is recommended at 200 milligrams and 300 milligrams once daily. Looking at Utah Medicaid PA and claim from 2019 to 2020, Descovy have no prior authorization submitted because it's a refer. Truvada have total of 26 PA. Within that, 17 was approved and 9 PA was denied. Descovy have 407 claims versus Truvada as 182. Descovy has 90 unique patients and Truvada has 45. Looking at other state referring drug lists, these stay at the SSDC state. Delaware, Iowa, Maine, Mississippi, North Dakota, Ohio, Oregon, and Vermont. They have both Descovy and Truvada in the refer. West Virginia refer Descovy and have Truvada as non-refer with some criteria, as Truvada shall be treated as refer when prescribed for PrEP in member aside female at birth. Truvada may also be approved over Descovy, where guidelines clearly indicate superiority over Descovy. Wyoming refer both Descovy and Truvada with clinical PA. The proposed referring drug list, currently Utah Medicaid have Descovy as refer and Truvada as non-refer. We would like to make a proposal that starting next year, both Descovy and Truvada will be considered for refer. And that concludes my presentation. And I'm happy for any question.
Great, thank you, Noon.
Thank you.
All right.
Is there a way to, is this a good time just to make a comment? I don't know how to raise a hand, sorry.
Sure, go ahead.
Sure.
Just looking at this, I really agree with this. I did to make them both preferred. Thinking about it, women who have receptive vaginal sex who are on Medicaid, who might have a partner who has HIV because of drug use or other issues, they are the group that really has not been, they're not covered by Descovy. And so I'm, that data is not there. And I'm grateful that we have a way now to help that particular population that doesn't have as much of a voice as many of the other groups have that have been PrEP.
Yep.
It also occurred to me, just in looking at the data, and I don't know if you have the overlap between those categories and drug use and sex work, but I think sometimes those lines are blurred. Mm-hmm. And I wonder where this drug fits in the setting of substance use treatment. Just raised a lot of questions for me. I mean, there's a lot of information packed into your report, and I really appreciate it. But I'm sure that there's a lot of opportunity, as was just pointed out. to reach populations that have been underserved, and that might be particularly a focus in that setting. Thank you.
Thank you. Any other comments?
We do have 2 public comments,
Yeah, that'd be good.
so we can move on to that.
Mm-hmm.
So our first one we have is Dr. Susanna. Apologize for not pronouncing the last name. Is Dr. Keeshan. I don't see her on here. Wonder if she's one of the one that called in. Dr. Keeshan, are you available to speak? Well, we can move on to the second one, and hopefully she is available. I'll send out an email to her right now. So the next one we have is Dr. Stuart Brockta, who's with Gilead Sciences. Brockta, sorry, Stuart, are you available?
I am. Can you hear me?
Yes, we can.
Yeah.
Okay, great. Thank you. And thank you for the opportunity to address the group today. I want to thank Noon for her very complete review, and would agree with Jennifer's comments about making both drugs available because of the indications for both covering the majority of patients. Excuse my voice this morning. It's early here in Seattle. What I'd like to do is not review the package inserts of these 2 drugs, because that information is readily available to you, and just give you a few highlights, in fact, 3 highlights of the differences between Descovy and Truvada, just for your consideration. I realize that you're recommending both, but I want to highlight the reasons why this is important. So Truvada is a safe and effective drug for HIV treatment and prevention, but it has known bone and renal adverse effects that Gilead has never hidden. They aren't high rates of these, but they are notable. And in HIV infection or in prevention, they are still relevant to this population. The 3 key differences that I want to point out are: 1, the renal safety differences, the bone safety differences with Descovy over Truvada, and the PK are pharmacokinetic profile differences, which were all seen in the Discover trial, which was the registrational trial for the approval of Descovy for PrEP. Renal safety. So there were significant differences in the impact on eGFR between the 2 arms of Descovy versus Truvada, with greater interquartile variation. What I didn't mention, and I think this is very important, is that the average age of the population in the Discover trial was 34. So this was not an old patient population, but the range was up into the 70s of this population, because as we know, people are sexually active through their whole life. So patients that are older do have comorbidities that make them at higher risk for bone and renal complications, but the younger population, which were more represented in this trial, still have comorbid events where bone and renal issues are important. Of note, we saw no Fanconi, and we have not seen any Fanconi, which is the most significant adverse renal effect that Truvada has been noted. We saw 1 case in the Discover trial with Truvada, none with Descovy. For bone, we did a sub-study. Not all patients in the Discover trial got BMDs because of the impracticalness of this. This trial was over 5,000 patients. And the reason it needed to be that high
Thank you, Stuart. Thank you. Thank you, Stuart.
Okay.
Thank you for the time.
Okay. All right. And I would like to answer any questions if you do have questions. I didn't really address the PK, but if there are any other questions about the details of this study or differences, I'd be happy to address those.
Any questions?
Is there any data on PrEP use in heterosexual women for Descovy?
So thank you for that question. And we did attempt to study that in the Discover trial. And because of the incident rate being so much lower in that population, in order to get it powered, it would have taken an enormously large study, even much greater than what we currently had. So we attempted to do it in the developing world, which the incident rate in heterosexual women is much higher. But we had challenges doing that. We are currently in the process of having that study occur, and it will be mostly in the developing world. So what we do have is kinetic data to show that in women, it should work the same way as it does in men, but the FDA did not choose to accept that for labeling purposes. So at this point, we can't recommend it, but we have no reason to believe it should not work as well. And that's our official statement, but we are studying it. Thank you.
Thank you.
You're welcome. Thank you for your time.
Yep. Did we ever track down our second public comment, Mo?
No.
Okay. All right, then I guess we move to committee action, or at least committee discussion.
I would suggest we move to proceed with the recommendations made by Nguyen on the both becoming on the preferred side of the list.
No, I would also note that the P&T committee is responsible for recommendations pertaining to the preferred drug list. And
never mind.
that's all right. But it's informational and it's good. I think it was a great presentation.
All right, does that mean we are done with our agenda?
Yes, we are.
Great. All right, we made good time today. So advised, yes. All right, so I guess next meeting, we're going to be talking about Evrysdi and Viltepso, and so I guess we will adjourn for now. Yes, good luck, Mo. We will miss you.
Thank you, guys. Thank you. Definitely will miss everyone as well. I've learned a lot from this experience as well. So I really appreciate meeting you guys and working with you guys. It's been a pleasure.
Thank you, Mo.
Where are you headed?
I miss you.
I moved to California, so we're closer to family. So that's been one of our top priorities. So now looking for jobs. So
Where
you guys do know any PBM or the ones pharmacists, please let me know.
What part of California?
Southern California, so Chino Hills. It's about 45 minutes east of LA.
All right, best of luck.
Thank you so much. I really appreciate it.
All right, then we will consider ourselves adjourned and we'll see everybody next month.
Thank you.
Stay warm, stay safe.
Thank you, everyone.
Thank you, everyone.
Bye, everyone.
Stay safe, everyone. Thank you.
Bye-bye.
Thank you and good luck, Mo.
Thank you. Thank you. We'll just wait if anyone has normative feedback. we are good to go.